very distinct area to focus on. I took the hospital and the ambulatory care services, the emergency department, and 3 hospitals that were affected by this storm, Sandy. But I'd like to put in perspective that a decade earlier, World Trade Center was bombed, and it was a sense of the hospitals were there. It was a more universal perspective of who was involved, and there was a lot of focus on many people. Always, I think, in the face of the organization of our medical system, we ignored the most vulnerable and disenfranchised, but we paid better attention and seemed more universal in that particular effort. And what I'll try to show you now is that from the perspective of where I sit, there were really problems because you can see, I don't know if I have a pointer, but I think I'll have to get up. This is New York. These hospitals had been lost. St. Vincent's Hospital a couple years earlier. This is the Manhattan Veterans Administration Hospital, Bellevue, and the New York University Hospital. So those 3 hospitals together allow me periodically to feel that those are my jobs to lead emergency medicine there. That in principle, that those 3 hospitals are serving most of the people of the city, the people who have money, the people who were veterans, and then all other people, no matter who they are, can come in. And so you can feel in a day's work you can serve for all people. So the integration there is interesting. But those 3 hospitals were lost simultaneously. And I would say, whereas after the bombing of the World Trade Center, there was a sense of PTSD for the entire community of New York and maybe our country. In this instance, the greatest PTSD was certainly in many of the places where everybody had problems. Some were more extensive in one part of the city or states or others. But I think the leaders of the hospital systems had tremendous PTSD in thinking about their hospitals being lost. I think some of the logic, the things I'll discuss, relates to that. This just gives you a sense of the magnitude of the number of people going to these hospitals. You can see on the left is Bellevue, then there's NYU, then there's the VA. And those are all those people who had to be evacuated. Large numbers of people left in various stages for various reasons. There was a tremendous loss of access for inpatient and emergency department visits and ambulatory care visits. Probably you're dealing with several thousand outpatient visits a day. You're dealing with, in addition, 500 emergency department visits for those 3 hospitals, all gone, as well as obviously the hospital beds. These people were evacuated elsewhere, and that's another story. The next phase, and this has to, those are the 3 hospitals, the adjacent hospitals, the 2 hospitals that were still functioning. The one on the left, New York Hospital, was the trauma center, and Beth Israel was adjacent to Bellevue. So the staff, after the hospitals were evacuated, were sent elsewhere, distance. And I'll show you later. They went to probably 50 different hospitals in the city of New York, all based upon not race and creed, but by financial status. That the veterans were sent to the veterans hospitals in Brooklyn or in the Bronx, and the Health and Hospital Corporation staff were sent to the Health and Hospital Corporation hospitals, and the university hospital people were sent to the hospitals where there were private practice efforts. Devastating overcrowding in those 2 hospitals, beyond imagination. Walk-in services, as well as hospital services and emergency service, were stopped at the NYU, the Bellevue Hospital, and the VA. So no one could get in. Ambulances were rerouted at tremendous distances. And all of this, actually, for your effort, Reed, will be looking at the ASPR remarkable efforts in collaboration between the CDC, ASPR, and NIHS, once again under Nikki Lurie's wonderful leadership. We're all sharing parts of the research we're doing on actually what's happened. So it would be exceptionally useful, and 3/4 of the people are working on resiliency and looking at it from their community. So here you essentially protected the hospitals. This is really the Maginot Line of the 21st century. It was blocked it from anything bad happening to people who might get to the hospital, but they were sent, all these people were sent elsewhere, and was there service for them? And this is what the hospital logistics were. The ambulances were blocked off from the moving site. They were going in green to these 2 places. This is the Beth Israel Hospital, that's the New York Hospital. And then this is where the emergency department attendings were sent. And this is just an example of where they were sent throughout to Elmhurst in Queens, and to Kings County Hospital, and to the Bronx, and a host of places of quite a distance. So it became obvious to us really that the question was, why do hospitals and emergency departments and ambulatory care services exist? For a near perfect representation of the norm? Because everyone asked all day long as we looked at this, what if this happened in this place that's probably wet or moldy or something? Although much as we had, essentially, there were people and there were buildings. But how do you go ahead and meet the needs of the community? What is to be done for the people who live there since everything had been evacuated? The buildings had been evacuated. All the staff who could render health services were sent elsewhere. So what was going to happen to this community? And this, as the healthcare deficits in the particular community increased dramatically, one wasn't certain what happened. Each hospital had a system, very effective, to send people 24 hours a day to other hospitals. There was a greeter at the door to send you away. And that went on for weeks, just to send people away. And there were ambulances ready to transport people who came in and day out with crushing chest pain, because they knew that if you got in an ambulance, you'd be taken someplace else. And they only spoke Bengali, or they only spoke Hindi, or they only spoke Mandarin, and they knew this hospital could do it, or their doctor had been there, or they'd been born there, or their records were there. Or I have my clinic for Coumadin that I've been followed here for 20 years, and my heart valve isn't going to make it unless I get to this place. Well, we sent them elsewhere in all of those hospitals. I only have my only psychiatrist is there who's helped me, and I'm depressed. How do I get something going? So this shows you, again, this is what happened. The blue is Bellevue Hospital. The green is Beth Israel, which is adjacent. So Bellevue drops to nothing after this one, and Beth Israel goes up. But you can see that the effort for Beth Israel isn't double what it should have been, isn't double what it had been before the storm, and so patients have gone elsewhere. And where did they go as part of the process? They didn't go to New York Hospital either. So everybody went up, but those 500 additional emergency patients didn't get to emergency spots. And you'd say maybe that's good because so many people don't need emergency care. On the other hand, the people who demonstrated they didn't know the difference of when they should go by ambulance or when they should walk. People came in with catastrophic problems or neglected catastrophic problems because their health literacy or their health numeracy wasn't good enough to handle this type of crisis. So, can a city or state respond to a disaster without universal health care? Can you, if you have to divide the providers up by race or class to send them to different places, can you really meet the needs of the community? You'd think in a disaster, or I would always hope we'd have universal health care to respond to the needs of our society and do better than we do. But you'd think at least when something destroys the infrastructure of the city or a country, that you'd have a system that can bend their rules enough so that a guy who works at the VA could conceivably work at a hospital run by the city of New York by a private hospital. Can't we structure that way? You know that we've discussed with the state and our representative right here, we talked about the fact that I would send those doctors out to those hospitals and they'd sit there for days or wandering around trying to get their credentials accepted, even though they all had the same credentials at New York University, and many of them had the same credentials at the Health and Hospital Corporation, but they couldn't go to any other hospitals to function for days. And that's at the same time that none of the people in the community were getting services. So Virchow set a high standard, but medical education does not exist to provide students with a way of making a living, but to ensure the health of the community. He said that in 1850. I modified it for this talk. Healthcare should not exist to provide healthcare systems with a way of making a profit, but to ensure the health of the community. Something pretty simple. Essentially, there was no universality of response. There was a codification of response. Sure, it was difficult, and if you studied Heisenberg, you'd recognize for us to go to work every day, by January of 2013, at the New York University Hospital was open. The emergency department was closed. If you went a couple of blocks down the street to Bellevue, 4 blocks down, the hospital was closed and the emergency department was open. You went further down to Manhattan VA, the entire hospital was closed in January. So it was pretty complex for patients to understand. It was impossible for doctors. It caused tremendous concern for nurses and every other staff, but the patients really had nothing because for the longest time they couldn't get the kind of things that were essential. So this is, I think that this lack of universal health care is a big deal all the time. But if we can't solve it in the face of disaster, and really think about, as we always have tried to think about, the most disenfranchised, the most medically underserved. But what I try to portray by some of those notes, that many people are fixated on their hospital, have imprinted in that system, and make it because of that. And it's a fragile enough system that there's got to be an immediate response. And so I gave this to you in several formats, but try to say what we should do for ambulatory care, emergency care, and the end results. And the objective really is, as we pleaded for weeks, is to get something open immediately. The doctors and nurses and clerks and every person was fine. Sure, we didn't have heat in our homes, we didn't have running water, we didn't have lots of ways to get there, but enough people could get there to function. And we could have functioned immediately in a safe space. And there's a 26th Street Armory, there are a host of other things. There was the hospital, was okay to work in. The DHS and FEMA said they'd give us immediately backup support to put something up. But people said we can't do things like that. They can get elsewhere. Well, it took weeks to get people to believe that needy people in the midst of the crisis that they had needed some support, even if it was a good place to talk about things or to make sure you got your medicine or to use the systems that we were so well adapted to do. And people were ready to work and didn't have a place to go to work, as well as to serve. So, you know, your end results would be immediately to work on resiliency and community health and public health needs and focus on the essential needs of the highly vulnerable, which the New York City Health Department has lots of information about: who's electronically dependent, who's on dialysis, who's going to get home ventilation, things of this nature. And you'd go to the next phase would be to reestablish your primary care clinics, get people back into the things they need. One could do that very easily. One could set up an emergency department that works 24 hours a day. Ultimately, one moves to a system where it might just be urgent care. It might be people walking in. We were getting, at each of these 3 hospitals, we're getting 50 to 100 people walking in and being sent away every single day from the day the storm hit. And then we were getting these same people, and when we started to bring them in to see an urgent care effort, just to get things going. And then the next phase would be to move to a higher level of services. And by the time that you felt there was a way to move the city that was easy to transport people, we know that freestanding emergency departments make a difference. You can get 90% of the people who were brought there by ambulance are going to end up being sent home and cared for, and then sent on the other 10% to another hospital. And we had agreements. We had to have repatriation contracts. If you sent someone who was too disenfranchised to a place that didn't take people who were supposed to be not disenfranchised when they came to the door. So you had a host of things that really expands conceptually what we believe EMTALA does, Emergency Medical Treatment and Active Labor Act, and we were going to say that you had to do this all the time. And you had to bring the people in the hospital, you had to care for people, and you had to find a way. And it's the bottom part of the process is that those 3 hospitals could function together to do remarkable things. Separately or independently, there are probably tremendous deficits everywhere. But if you needed someone to do good Mandarin translation, you're not going to get it in a lot of places. And so being sent just anywhere doesn't make a difference. And doing the things that these hospitals are built to do have to be replaced, since the people were there, and lots of it was functional, social, public health, medical systems were probably far less consequential in this phase. But you had people to use. The question is how to use people effectively in a society to make it work. And these are some suggestions.
Thank you very much, and we'll get to the Q&A. I have a bunch of, I know all of us do. Scott, you're on the phone, and you are the Vice President of Clinical and Business Services for Monmouth Ocean Hospital Service Corporation. Scott, take it away. We have your slides up, and Lauren is driving them.